She is related to the Gartland who used to be a pediatrician at Newton-Wellesley Hospital, though.
Oh, there you
Hi,
go.
Matt Garland.
How are you, Larry?
Okay, I'm going to get started. Hey, good afternoon. It's John Snyder. Welcome to another edition of Newton-Wellesley Medical Group Lunch and Learn. We're excited to learn about our thyroid clinic and our thyroid biopsies today. So thank you, Dr. Gartland, for coming. We just want to tease the upcoming Lunch and Learns. We have next week, Dr. Kosha Thakur. We're excited about her talk on microaggressions. And then the following week, we have Dr. Jason Simon giving a talk about what a pain in the leg. And just a reminder that Thursday, November 11th is a hospital holiday. We will not be here. All these talks are archived up on our intranet, Newton, as well as also up on Newton-Wellesley Medical Group Lunch and Learn on searching that on YouTube. Next slide, please. Given the volume in the emergency department, kids getting back to sports, we want to remind all our folks on the call that we do have our Newton-Wellesley orthopedic walk-in, which is open 7 days a week. It's a walk-in service. No referral is, well, referral may be needed, but you don't need an appointment. You can come on in Monday through Friday, 8 a.m. to 8 p.m. And we're also open on Saturday and Sunday. We have x-ray, casting, bracing there. We are staffed by orthopedic physician assistants and board certified orthopedic surgeons, one of which is Dr. Jason Simon, who'll be talking to us in a couple of weeks. Next slide. Before we let you get on, I also want to tease our Wednesday morning, our Dr. Freeman's Wednesday morning grand rounds, which is an excellent place to get really great talks, 8:30 a.m. And that should be coming out to you through the medical staff. If you're not getting those links, please give him or me a call and we will go ahead and take you. And I will stop talking and Dr. Gartland, take it away. Thanks.
Thank you so much. Hello, everyone, and thank you for inviting our clinic to present today. My name, like John said, is Rashri Gartland, and I'm a surgeon focused on thyroid and parathyroid surgery. I also have the privilege of serving as surgical director for this new thyroid biopsy clinic, which is what we'll talk more about today. I have no disclosures. So the MGB Thyroid Biopsy Clinic at Newton-Wellesley is a recently launched clinic that essentially provides a one-stop shop biopsy experience for patients and nodule guidance from a group of endocrinology, endocrine surgery, radiology, and pathology providers. We launched the clinic last month and thus far have seen about 70 referrals, have had about 70 referrals, and have also seen or booked 60 patients since the first week of September. So today I'll briefly introduce the team, our clinic structure. I'll review the current American Thyroid Association biopsy guidelines, discuss what patients need before coming to the clinic, review how to refer a patient to clinic, and touch on the post-biopsy follow-up. And fortunately, many of the folks from our clinic who are on the call right now, and we would be happy to take any questions at the end. So I'll start by introducing the team. The administrative leadership of our team includes our service line manager, Hillary, and practice manager, Mary Ann, and both have really been integral to our launch. Our support staff here, you can see Ashley, who helps with scheduling and referrals, as well as Stephanie, who's our medical assistant. Megan is our physician assistant who works closely with our referring providers and clinical team to help triage biopsy requests based on published guidelines, which we'll go over. She also attends every clinic and helps care for all the patients we see. This is our all-star endocrine team, Dr. Yasa, who also serves as medical director of the thyroid biopsy clinic, and Dr. Sahin Efe, who serves both as very knowledgeable endocrinologists, and they also perform biopsies. And then this is our team of surgeons, which includes myself, Dr. Otremba, Dr. Stephen, and Dr. Parangi. Many of you know that Dr. Parangi is the chair of the Department of Surgery and also is the person who had this vision for this clinic about a year ago. She's also available, as we all are, to consult during clinic if anybody needs a surgical referral. Another wonderful feature of the clinic is that we have this cytopathology team led by Dr. Abbott and cytology supervisor Ashley Taylor. We couldn't include all their pictures, but we're very thankful for the many techs and trainees who join us every Tuesday to make sure that we have adequate biopsy samples. And this is so great for patients because it really decreases the chance that they'll have to come back for another biopsy if the sample isn't adequate. Our radiology team is led by operations manager Jessica and also Dr. Iqbal, who's the director of interventional radiology, and will be helping with difficult biopsies. We also have several excellent ultrasound techs who join us on these days. So with that introduction of the team members, a little bit more about the clinic structure. So the thyroid biopsy clinic occurs every Tuesday morning from 8 a.m. to 12:30 p.m. And every patient is first evaluated with a history and physical and review of their records just to make sure that a biopsy is appropriate. Every clinic is staffed by at least one endocrinologist. And like I said, there's always a surgeon available at every clinic in case a consult is needed. As mentioned before, we have an on-site cytopathology team to help ensure adequate biopsy samples, and also radiology and interventional radiology support twice a month. So now the question that's on everyone's mind, to biopsy or not to biopsy? And I thank Dr. Otremba for this clever title. So first, it's important to think about thyroid nodules. We know that thyroid nodules are common, and in fact, 60% of all women will have thyroid nodules by the time they're 60 years old. Of all these nodules, about 5% will ultimately be malignant. So the key components of working up any thyroid nodule include an H&P, a TSH, and an ultrasound. And the TSH is really critical for determining next steps, since a low or suppressed TSH would prompt a hyperthyroidism workup and likely radioisotope scan, whereas a normal or high TSH may prompt a biopsy. So thinking about, this particular category of nodules, which ones should get a biopsy? And this is certainly an answer that has evolved over time. In the 2009 ATA guidelines, it was recommended that pretty much every nodule greater than 1 centimeter be biopsied, as well as nodules with worrisome imaging characteristics or in patients with significant family history. In 2015, the American Thyroid Association updated these guidelines, and now the size threshold really is dependent on imaging characteristics. For instance, for intermediate or suspicious nodules, the recommendation is still to biopsy any nodule greater than 1 centimeter. And as you can see here, some of the suspicious characteristics include microcalcifications, hypoechoic irregular margins, lymph node involvement, etc. The main difference from the 2009 guidelines involves the management of lower suspicion nodules. So currently, a low suspicion nodule warrants biopsy if greater than 1.5 centimeters. And a very low suspicion nodule, such as a very spongiform nodule, warrants biopsy if greater than 2 centimeters. And of note, these recommendations are based on estimated risk of malignancy based on imaging characteristics. So naturally, the question comes up, do ultrasound reports provide biopsy recommendations based on these guidelines? And the answer is most of the time, since it's not standardized across hospitals right now, there are some radiologists that have started using the TIRAD system, which assigns points to the different imaging characteristics we went over, and then recommends a biopsy and a size threshold based on the total number of points. And this is really helpful and a move that we've started to make even here at Newton-Wellesley. Of course, every case warrants consideration of other factors as well, including patient radiation exposure, family history, compressive symptoms, PET FDG avidity, lymph node involvement, personal or family history of thyroid cancer, and other factors that may increase a patient's risk of malignancy. So in summary, when we're thinking about whether or not to refer, you can use the TSH, ultrasound, and patient history as a guide. But of course, when in doubt, reach out. What really makes this program unique is that we have experts, the whole group, but also Megan, who are really able to help triage patients based on these guidelines. And we're here to help. So what does a patient need before coming to our clinic? It is ideal if a patient has an ultrasound within the last 6 months, and this doesn't only include the report, we like to have the images as well. Also a TSH within the last 3 years, and then if they've had prior biopsies, it's helpful to have a copy of any of those reports. And then how exactly to refer, I just wanted to go over that. There's really three main ways. The first is a referral through Epic, and I want to thank Adam Deming for helping us put this together. But basically, if you are putting in any order in Epic and you search thyroid biopsy, you'll get an option that says ambulatory referral to Newton-Wellesley Thyroid Biopsy Clinic. And so you can click on that. And this will prompt a few short questions and then be forwarded to our triage team. In addition to this, you can also call, and I just want to put that number out there again, and also email us. And then in terms of next steps, so once a patient gets a biopsy, their results could be one of 6 Bethesda criteria. And this includes non-diagnostic, which I think fortunately is reduced since we have a cytopathologist on site with us to make sure we have an adequate sample. The result could be benign. The result could be indeterminate, which includes 2 categories, including atypia of undetermined significance and follicular lesion of undetermined significance, as well as follicular neoplasm or suspicious for follicular neoplasm. Or you could be in a Bethesda 5-6 category, suspicious for malignancy or malignant. And I put up this chart because it's important to see that each of these FNA results is associated with a certain malignancy risk that helps us recommend next steps. So after the biopsy appointment, we call patients with the result and forward this information to the referring provider. If a result is benign, we will offer guidance to the referring provider regarding surveillance and regarding situations in which the patient should be referred back to our clinic. If the result is indeterminate, so those Bethesda 3 and 4 categories, we'll likely proceed with molecular testing. And again, fortunately, we acquired this sample needed for the molecular testing at the time of the initial biopsy, so it doesn't require any additional biopsies for the patient. And this can sometimes help guide next steps. And then if the result is suspicious for malignancy or malignant, we can help arrange referral for thyroid surgery. And then I wanted to, lastly, in terms of future directions, in addition to growing this program, we're planning to launch a thyroid radiofrequency ablation program in the coming months. And this will be a minimally invasive procedure that we'll be able to offer to mostly patients with compressive or autonomous benign nodules who do not want to undergo surgery but have symptoms. And there's more to come on this in the future, but just wanted to give a heads up about that. So I know I ended way early than expected, but that will leave lots of time for questions, and I'm happy to reference back to any of the previous slides. Again, there's lots of ways to reach out to the clinic, but you can also reach out to me with any questions whatsoever. And I again have the number for the thyroid biopsy clinic right there. Please. And if any of anyone on here on the call from the thyroid biopsy clinic wants to chime in about anything that we spoke about, please do so. Thanks.
Thanks, Rashmi. It looks like there's a question in the chat about who does the initial H&P. Perhaps that is someone in your clinic. That's the same person.
Yeah, that's me, Carrie Lubitz. I'm the section head of endocrine surgery at MGH now. This looks amazing, Rashmi and Soraya. I know this is been a big undertaking, and absolutely having everyone in clinic at the same time is critical, and having a cytologist there is key. So I'm very excited about it, and it seems like you guys are already doing a great job up and running. So my question was, you said that you guys do the H&P, but I see that there will be a lot of H&Ps done where these are found elsewhere. I didn't know if you had a separate clinic where you evaluated patients, or you are using the H&Ps that have already been done. It was a little confusing to me. And my second question is molecular testing an automatic reflex? Meaning, do you talk to the patients beforehand about whether or not that would actually help them make a decision regarding surgery or not, or if it's an automatic send?
Those are great questions. So we review the outside records for every patient, and many of them will come with their own separate evaluation, history and physical. But in addition to providing the biopsy, every patient gets a fresh history and physical from the providers in the thyroid biopsy clinic. So on the 4 Tuesdays, the patient is either seen by an endocrine surgeon or otolaryngologist or an endocrinologist. And we, no matter the provider, we will do that. There is an occasion where our personal patients who we've already seen in clinic, we recommend just getting a biopsy done. And so if it is actually one of the providers, or say if you had a patient that you had already, done the full evaluation, but they're coming exclusively just for the procedure, we can do that too. And we usually just book that for a shorter visit.
And it'll all be on the same day.
Yes.
That's my question, really. Okay.
All
Great.
on the same day. One happens right after the other. And we fortunately have multiple rooms. So, multiple patients can be evaluated at the same time. And then we switch off in the biopsy room. And then regarding molecular testing, while we get the sample at the same time as the biopsy, it is not reflexive in that we talk to the patient for every case, and only if it would really help decide next steps in management do we recommend moving forward with that.
That's great. Thank you.
Thanks. I want to ask a question right on top of that about the patient journey through the clinic. So a lot of times I'll send a patient somewhere, they want to know whether they're going to get the biopsy that day, or is it typical that they will actually get a biopsy that day, or what can we expect to tell the patient about that?
Yes, absolutely. The part of the pre-clinic screening is to ensure that everything is set up such that the patient can see these providers and get the biopsy all within the same visit. This is meant to be a patient-centered, one-stop shop experience for that patient. So while they do have to have their original ultrasound and imaging beforehand, once they come to the clinic, the idea is to get everything done. And that also becomes relevant because one of the things we do is if a patient is on anticoagulation and they're going to need to stop that ahead of the procedure, we reach out to the referring provider or the patient's cardiologist, et cetera, to see if that can potentially be stopped for 1 or 2 days or whatever time before the biopsy, knowing that when they come, we would like to get that all done at the same time.
That's great. There's a question on, do you also deal with parathyroid cysts and parathyroid adenomas in the clinic?
That is a great question. So this particular clinic is for thyroid biopsies, but in the afternoon of every Tuesday, our endocrinologist, one of our endocrinologists, Aisha Sahin Efe, has a endocrinology clinic. And on the 3rd and 4th Tuesdays, following the thyroid biopsy clinic in the same space, I also have a thyroid surgery clinic. Thyroid and parathyroid surgery clinic. And so there is always a provider around to talk about parathyroid issues, but that's mostly in the afternoon.
And those would require separate referrals to either you or to Africa.
You can actually call via that same number because it's the same clinic space. You would be able to use that same number on there to be able to book that appointment. And we have so many wonderful providers in the group that if that day doesn't work, there are both other endocrinologists and endocrine surgeons that would be happy to see any patients with any parathyroid issues.
And then there's a question. Go ahead.
I would add to that. Hi, it's Lila. So from an endocrinologist standpoint, I would suggest that parathyroid biopsy be thought of at the point where you've established a diagnosis, are thinking about surgery, and are hoping to localize a lesion. So if you have somebody who just has a newly elevated calcium, parathyroid dependent, and you want to see, a lot of those patients end up being medically managed. And so you could also start with an endocrinology consult, and then we would make use of this biopsy clinic to do parathyroid sampling if that was needed. A lot of times that's not needed. So you could go either route, and I would say it would be more based on how firmly the diagnosis has been established biochemically and what imaging's been done and whether there's a plan for surgical management already in place.
Thank you, Lila. That's helpful, especially because we're trying to manage these findings as they come across as PCP. So thanks so much. There's a question about where physically you're located in the hospital. It looks like you're maybe pulling that up, or you want to tell them where the clinic is?
Yes, I should have included that, but we are in the green building on the 6th floor, and I can look up the exact suite number, but it's, yeah, I'll put in the chat the exact
no
suite
problem.
number.
That's no problem. Thanks. The only other question, I guess, I don't see any other questions here. One of the things that sometimes we struggle with as PCPs is when we get a nodule that's hot, right? So the TSH is suppressed. Would we not be sending, would we be sending to endocrine more than this to this clinic with that or no?
Yeah, that's a great question. And absolutely, that would be a patient that would probably be better suited for an endocrinology upfront visit. And as Lila mentioned, this is also a great opportunity for an endocrinology e-consult. If there's any question whatsoever, especially in a patient that might have, subclinical hyperthyroidism, but also has thyroid nodules that are causing symptoms, that's a great opportunity for an endocrinology e-consult. And in the EPIC referral, we have an option. There's a prompt to consider that if there's any questions whatsoever about referral.
Great.
John, it's Saray. Could
Hi.
I make just a quick
Please
comment?
do. Sure.
So I just, I know it looks like I'm like in the end of some room. I had to come here to be part of the consult, so I apologize for that. What I was going to say is, I think this is a great example of the kind of patient-centered thinking that happens at Newton-Wellesley. So obviously starting a new adventure that requires 6 groups to come together, including ENT and radiology and medicine and psychology and pathology and APPs, and everyone is not easy. But I would say it was actually easy at Newton-Wellesley because everyone cares about the patient and really wanted to make the patient experience smooth. And this was a little bit of a gap where, we felt that PCPs were sort of suffering, with the advent of incidental nodules and then, the follow-up and how do I get molecular testing. And so we wanted to make it easy, but then the system made it easy, like the PO and the CMO and everyone supporting it and medicine and all the chairs of the different departments. So I just want to point that out that, I really, really appreciate that and all the effort that Rajshri and Layla as co-directors have put in. And administration, Hillary and everyone really working hard. We had to renovate space actually to accommodate this area and make it feasible. So really thank you to the team and thank you Rajshri and Layla for leading the charge here.
Yeah, I would guess some of the PCPs who've been struggling with this like me for the last 15 years, thank you for putting this together. It makes it easy. Saray, you gave a talk on thyroid nodules, it must be a year ago or so, and you were talking about the different molecular diagnostics that we were going to try to have to order as PCPs prior to sending people to thyroid biopsies. And that was making me dizzy. So we appreciate you guys managing that for us. There is a question, a comment about putting the thyroid nodule clinic info into the endocrine or ENT smart phrases. And I will take that to Rick D'Angelo. He'll put those in there and we'll get that information. It's a great suggestion. Thanks.
Yeah, and let us know if you need any help with that. We're happy to provide any language.
Perfect. Great.
And I'll just add one last thing, John. I think, it is the goal of MGB, right, to put the right care at the right place. And this is a good example of that because we do want to do more endocrine surgery at Newton-Wellesley. And we have amazing surgeons. We have amazing ENTs who do great work. And, 99%, maybe 99.9% of thyroid surgery can be done at Newton-Wellesley very safely. So it's a growth of the whole program. Obviously, most thyroid nodules are benign and don't need surgery. So that's not like the purpose of this clinic, but it's to help all the patients and everyone get the right care.
Terrific. Well, Rajshri, thanks so much for putting this together and continued success at this clinic for all involved. And hope PCPs will continue to refer and send people there and send any feedback. I know everyone's interested in the feedback from the patient journey, how it goes over there. And we're wishing everyone a happy weekend, beautiful Thursday and Friday, and not over yet for the Red Sox. So everyone can still continue to root for them. It's all right. Got a couple games ahead of us. We've done worse. So we'll see you all next week with a Coach at the Course Talk. Thanks very much, Rajshri.
Thanks. See you all.
Bye.